All right. I want to welcome everyone tonight to the Baltimore County Fire Department Emergency Medical Services Academy Training Series. Uh, Tonight's topic is going to be extracorporeal uh, cardiopulmonary resuscitation. We are honored by having Dr. Sid Dante, who's an assistant professor of pediatrics at the University of Maryland, and he's the medical director for the University of Maryland Pediatric Intensive Care Unit. He comes to us uh, through residencies in Chicago and a fellowship at Johns Hopkins, where he trained in pediatrics, internal medicine, and pediatric critical care. He did a fellowship at Johns Hopkins, and he was recognized there with teaching awards for the residents and the junior fellows on his education and training. He has an interest in resuscitation with a focus on extracorporeal life support and the transport of critically ill children, a topic that's very important in the field of emergency medical services. And all of this started as a paramedic prior to his attending medical school, which makes him an incredibly amazing person. So without further ado, I'd like to welcome Dr. Sid Dante to us.
Thanks, Dr. Sagal. Just pulling up my talk. So, as Dr. Sagal said, I'm currently at the University of Maryland, where I'm the medical director for our pediatric intensive care unit. But I do kind of trace my time in medicine back to being a volunteer EMT when I was in college in New Jersey, and then getting my paramedic and working as a paramedic in Trenton, New Jersey, and then down in Richmond, Virginia, where I also attended medical school and continued there. So my time in resuscitation goes back to that period, which is kind of why this is a topic that's kind of near and dear to me. I kind of focus on pediatrics because kids generally get better. And when we do kind of Hail Mary techniques, they often have a good chance of working. So this is a kind of a broader talk. So I'm going to be talking about pre-hospital E-CPR, which stands for extracorporeal cardiopulmonary resuscitation. And I'm going to talk about the why, the how, and then the should we. And kind of it's a dense talk. I will kind of briefly go over what ECMO and extracorporeal life support is, kind of go into some of the studies that support it and underpin it, and some of the kind of intricacies of in-hospital, E-CPR that we have in place, and then kind of briefly talk about who potentially are the right candidates for it. I do have the chat up, so if at any point anyone has any questions, feel free to put it in the chat. I know that Dr. Sagal is a cardiac anesthesiologist, so if it's anything related to kind of ECMO, E-CPR, he'll be able to answer those as we go along. And I don't mind getting interrupted, and I would love for this to be a discussion or have some time at the end. So without further ado, my objectives are to define E-CPR and its role in managing cardiac arrest, discuss the history of and the evidence for it, outline the essential components and the role of various team members, and then discuss E-CPR candidacy. So as all good talks should start, it should start with a case. This case comes out of Texas, and it kind of shows and challenges, everything that we do, which is, this boy survived 90 minutes of CPR. And, for them, it was a novel thing because, he had an original arrest in an outlying emergency department. He had 60 minutes of CPR, and he got return of spontaneous circulation twice during that period. And he underwent E-CPR that they'd not previously done at adult children's at the time. And it took him from that 60 minutes an additional 30 minutes to get on ECMO. And as you can see here, him visiting, I think, the fire department who initially brought him in, he is a otherwise vibrant child. And the reason that you know that this story is true is you can see the scar on his neck here, because in pediatrics, we'll place patients on ECMO through the neck. And you can kind of see where they placed him on ECMO there. So where does kind of E-CPR come into this? So from Australia, there was the trial called the CHEER trial, which was in refractory cardiac arrest, given mechanical CPR, hypothermia, ECMO, and early reperfusion. This trial dates back to the kind of the mid 2000s, where they took 26 patients who they defined as having refractory cardiac arrest, so greater than 30 minutes. They included both in-hospital and out-of-hospital patients. That was neatly broken down between the two. And they placed them on ECMO through the kind of coordination that we'll talk about later. Of those patients, about 14 survived. And many of those, I think 11 out of the 14 with good neurologic outcome, which is what we care about. So when we kind of, for this study, kind of challenge the paradigm of, how do you rescue refractory cardiac arrest? So when it almost feels like it could be the flip of the coin. Now, this is not every single patient who presented, and you can kind of see that the initial rhythms in these patients, so out of hospital cardiac arrest, all patients that they considered had ventricular fibrillation. In the in-hospital cardiac arrest, the majority had ventricular fibrillation or ventricular tachycardia, and they were able to kind of achieve return of circulation in both, wean a decent number of ECMO, and of those they've been able to get off ECMO, have them get to survival. Now, while this was in the Australians and the adults, in pediatrics, we've actually been doing E-CPR for a bit longer period of time. And, when we kind of have compared, for us, E-CPR was largely the realm of the cardiac ICU. So generally patients who underwent cardiac surgery and had an untoward event in the recovery from it. And if they had an untoward event, they would receive in those areas E-CPR. And this study kind of combined all of those centers that had both ECMO and E-CPR and compared conventional CPR for greater than 10 minutes versus E-CPR. And while the majority of patients received that conventional CPR, we can see that the outcomes for our patients who received E-CPR was higher, and it was and likely beneficial. When we look at the mode of CPR, we look at other. When we look at the mode of CPR, we recognize that it's not just survival; it's also favorable neurologic outcome. And I do harp on that because just living is not good enough. I think that's what we want to do in our field and what we're trying to do. And so it's also not just looking at, can we get these patients alive to the ED? Can we get these patients alive to the ICU? Can we get these patients out of the ICU? Can we also get them back into the workplace or what they're supposed to do after that? What we've seen since then, and so this study was probably in the mid 2010s, this study from just a year ago, from about 5 years ago, combined all the E-CPR outcomes and resuscitation from 2 different databases, and include about 540 children, and kind of looked at both how much we're using E-CPR. And as you can see from the early 2000s, E-CPR was in the single digits to double digits, and has kind of steadily risen in the pediatric population in these hospitals, to higher digits for it. We recognize that there's a lot of factors that involve that. There is a number of children, so this isn't a 100% survival. About 40% of the children that were placed on ECMO via E-CPR died prior to decannulation, and the majority of the patients, even if they did survive, died prior to hospital discharge, and that there was factors that were associated with the higher odds of death. And while we'll talk about the time from onset of CPR to ECMO initiation, other factors included non-cardiac diagnosis and renal insufficiency, which kind of fits with among the things that we're talking about. So what is E-CPR? E-CPR is a rapid deployment of veno-arterial ECMO to provide circulatory support in patients for whom conventional CPR is unsuccessful. And I will say kind of our goal is a deployment in less than 40 minutes, and I'll keep coming back to this, especially when we talk about the different steps that are involved. So briefly, what is ECMO? So veno-arterial ECMO is the use of cannulas, an external pump, an external oxygenator to drain blood from the right side of the heart through generally the IVC or the SVC, and return it back into the aorta, thereby being able to perfuse. We do this using long cannulas and large cannulas, and we talk about the drainage or venous cannula and return an arterial cannula. And there's multiple ways that we can do this. In children, generally with their femoral arteries and veins being pretty small, as they're not up and walking and there's not as much blood flow as a walking adult, we cannulate actually through the neck. We go through the carotid and the internal jugular to place our cannulas in the right atrium and return it back to the aorta. What you can see on this picture, and you'll see on multiple pictures, is that the overall ECMO machines and circuits, as complex as they can often look, oftentimes are just the simple things, which is simply just a pump where we pull the body out, pull the blood out of the body, able to circulate it to be able to push it through what can be called a membrane lung or an oxygenator, and then return that into the high pressure system that's the lung. So in children, in infants, and probably young children up to probably the age of 10 to 12, about the time they start getting adult size, will generally go through their neck because that's where we can place the appropriate size cannulas. In adults, the often spot that will go is through their femoral arteries. We'll be able to put in a large drainage cannula, which will go up through their femoral vein. We actually do want that cannula to go all the way up and travel towards where their right atrium is. And we want that to be in that position where it's going to be able to suck blood, and the muscular nature of the vena cava will be able to tolerate it. And then we return blood through a femoral artery so as to be able to provide circulation and oxygenation back. More complex, and for patients who are kind of in the operating room or have open heart surgery, we can actually place cannulas directly within the right atrium and return it right back to the aorta. This would often be patients who've undergone a sternotomy already for a cardiac bypass and are unable to come off of it. May not be something we do in the E-CPR mode, but it just shows you a different way, and also shows you that the external part to ECMO is the same regardless of where we put our cannulas. We also talk about the membrane lung. And the membrane lung generally is a proprietary device made by different manufacturers. But the basic concept of it is it's similar to the lungs that we use, in that we provide in blood that then saturates the membrane that's here. And here we can measure a central venous oxygen concentration similar to the venous oxygen concentration that we measure going back to our right atrium. We can provide oxygen in, and then the oxygen will come out. That will diffuse across the membrane lung, diffuse across the blood, and you'll have oxygen to blood be pushed back out. So overall, I mean, the goal of E-CPR is to do the same things that the lung does and the same thing that the heart does. So we often talk about ECMO as cardiopulmonary rescue or cardiopulmonary bridge to buy time to treat whatever underlying condition it is. So one of the things we'll say is that ECMO is not necessarily a treatment for anything. It's not a cure for anything. It buys time to treat whatever is the underlying condition, or buys time for therapy to work. So why are we here talking about this? So pre-hospital E-CPR, while in-hospital E-CPR is the thing that we've done, and we see that it potentially can be done. Can we take this? The time to ECMO is a critical component of what we are doing. And there are places around the world and the country that are really pushing this. So if you guys continue to get GEMS, the magazine, this is actually from about 10 years ago, where the mobile resuscitation unit in Paris started deploying and providing pre-hospital ECMO for it. Now the Franco-German paramedic EMS system, or Franco-German EMS system, is different from the US-based Australia and England EMS systems, where we generally will use paramedics and certified paramedics for our ambulance attendants, whereas France and Germany oftentimes use physicians. This is actually a separate unit, separate team called the SAMU that will kind of go throughout all of Paris for it. Now, some of Paris's unique aspects is the heavy traffic, the difficult streets, meaning that getting a patient from site to finish is very difficult. So the ability to provide E-CPR on arrival to the hospital is challenging. And the mentality of the kind of Franco-German is a little bit different, where they oftentimes do take a stay and play approach as opposed to a load and go. Which you see here with the French, that this is kind of a real case involving kind of the surgeons who are placing the patient on ECMO, the support personnel, closing down the entire subway, and then the machine, which is the same machine we'll use in the hospital, being able to provide the ECMO support. And we know the French kind of always are pushing, they believe in liberty and equality, but they'll actually push this even further, where this is actually right in front of that painting in the Louvre, where they cannulated the patient onto ECMO. One of the unique aspects of the Louvre is that the Louvre is, for anyone who's ever been to Paris, is a large facility that it can take just probably 10 minutes within the facility to get from where the ambulance offloads to the patient's bedside. So in some ways, that would increase your time to ECMO, time to CPR. that providing ECMO at the bedside, providing ECMO at the patient side potentially could be beneficial. One of the things to note is I believe that first patient in the subway did survive. The patient here in the Louvre unfortunately did not, but it showed you how the French were kind of pushing their limits. So they did write this up and they did publish it, where they did talk about that, they did kind of look at the different periods that they had. And period 1 was E-CPR in the hospital or field after 30 minutes of ACLS or transport time. They enrolled about 114 patients. 9% survived to discharge with good neurologic outcome. Now that's 9% of patients who would otherwise have died had they not done E-CPR. In period 2, they actually upped their period 1 was E-CPR in the hospital. Period 2, they created a mobile E-CPR unit where they deployed 20 minutes after ACLS. They had pretty stringent patient criteria. They limited the amount of epi they gave, and they simultaneously dispatched their E-CPR team at the time, and they reported up to 29% survival with good neurologic outcome. There was RCTs planned in Prague. London was looking into this as well. But one of the next most successful groups actually came out of the United States with Dr. Yiannopoulos out of Minnesota, who provided the same support, providing kind of aggressive E-CPR for patients transported to him. So they created a policy in where he worked in Minneapolis, where patients were immediately the appropriate patients were directed straight to the cath lab, where Dr. Yiannopoulos, who essentially was on call 24/7, 365 days, met the team there to place the patient on ECMO and then provide them any support. Patients were screened. The transport criteria here were they allowed ages from 18 to 75. They needed an out-of-hospital cardiac arrest with a cardiac etiology with an initial rhythm of ventricular fibrillation or ventricular tachycardia. They tried 3 direct shocks without ROSC and amiodarone. And then they kind of wanted them to make sure that they were getting good high-quality CPR using the Lucas CPR device, and whether they could get them into the cath lab in less than 30 minutes. So patients were transported to the cath lab with mechanical CPR and advanced cardiac life support going on. And if they had kind of markers of kind of poor outcome, such as an elevated lactic acid or really low oxygen, or the time had gone, they would actually terminate their arrest right there. But otherwise, they had ultrasound guided percutaneous cannulation for it. As you can see here, they kind of were able to kind of differentiate, what was done. And in this paper, they didn't necessarily have to prove that they could have patients survive out of hospital ventricular fibrillation cardiac arrest. They were actually showing a lot of good data that showed that there was a big difference between those who lived, those who died, and those who became brain dead. And you can see that those survivors, had the initial heart attack, they had the elevations in troponin, they had the decreases in function, but those who survived had marked improvement in outcome and marked improvement in their heart function over that period. Whereas those who did die or had brain death, clearly had other evidence for it. So it wasn't that we put them on ECMO and we wouldn't know for weeks whether or not they could survive or not. We'd know within days, and that's what this is showing here with the time in hours of the troponin and days with the left ventricular function. Other factors that played a role that they kind of described is, whether they had to use an intra-aortic balloon pump, whether they measured the lactic acid, and if they had to give any transfusions as well. And generally speaking, they generally showed that most of the survivors required kind of less overall support of ECMO flow. They required less vasoactive medications, and their lactic acid as a marker became stable. When you kind of look at also the same patients and we look at their imaging or their continuous EEG, 2 things that we routinely will do, you could also see a difference between those who survived versus those who died, and those who kind of showed us whether they had an oxic injury. No one had a hemorrhage in this, and only 1 patient had a stroke. But it generally showed that those who had survival with good outcome, which is very important for us, all would function well. So when we look at kind of like all the different trials that have been actually done out there, and we talk about refractory out of hospital cardiac arrest treated with advanced perfusion techniques, and that includes ECMO and PCI, you can kind of see the different areas that we would potentially cannulate, which could be the emergency department, the ICU, the cath lab, or even the field, that there's overall small numbers of these patients, because these aren't the number of patients that you go through. So in the Baltimore region or area, we probably are only talking about a half dozen to maybe a dozen patients, and that includes the county, the city, and kind of outlying. But we can see that we can get their survival rates of those who we place on into the teens, into the double digits, with a good neurologic outcome. And then it's important to also consider that a lot of these patients presented with refractory ventricular fibrillation or ventricular tachycardia. So Dr. Yiannopoulos has moved on and is also challenging the paradigm by, and getting grant funding to obtain an ambulance that allows him to place patients on ECMO closer to the scene, which involves which involves him being on call and training other people. What you can see here is not only the Lucas device up in the upper right picture that shows that we can provide high quality mechanical CPR, the size of the ambulance mock-up that they have, but also a C-arm so that he can visualize where he's going, where he's placing cannulas, where he's intervening, as well as an ultrasound device that's available. So it is a pretty resource intensive technique and therapy to bring to the field. In the pictures we saw from the folks in Paris, it's a number of responders. From the pictures here from Minnesota, it's a high level in investment in technology. So, it begs the question, what else is involved? So I loves art at times. I'm more of a someone who appreciates art by kind of being a bit more practical. So I'm sharing kind of the European ELSO, which is Extracorporeal Life Support Organization, which all kind of ECMologists are part of, released some art back in 2019 prior to the pandemic, where ECMO actually became even bigger, kind of demonstrating the different aspects. So to me, this piece of art kind of captures a lot where, there's a surgeon who's heavily involved, there's a lot of people standing around, and the wavy kind of cannula lines represent the chaos that we see there. So I don't think it'd be fair to talk about E-CPR ECMO without talking about some of the uniquer aspects related to EMS and providing kind of ECMO for it. So while we're probably far off in the Baltimore area from having a dedicated ambulance and surgeons who go out to the field to provide that, but maybe not that far off, we have to consider, it's not only our ability to provide, good critical care and good resuscitation for these patients, it's also transporting them safely in the process. And for many of us who've been in the back of an ambulance, we know the challenges with that. So I talk about this because this is something that I actually researched back when I was a medical student, building on my EMS background. And we were looking at, can we deliver high quality CPR in the back of an ambulance? So we looked actually to the transport literature, and this is subway literature. So in subways, they actually spend a fair bit of time, and especially with Germans, really trying to calculate how much force to drop in your, how much force that you need that might knock you off your feet, creating an unbalancing event that knocks you off your feet, that catches you to recover until you get full balance recovery, and try to minimize those amounts of time. Why is this important? And I'll come back to this a couple times. This is a landmark figure that I hope you've seen before, and if not, if it's the first time you're seeing it, anytime you do resuscitation, this is probably the figure I would want emblazoned in your mind. So this is off of a pig lab where they measured arterial blood pressure, which is the dark black line, and then right atrial pressures as well during compressions, which are these large periods, and then during periods of ventilation. What you can see here is, when we start, so this was a study probably in the late 90s or early 2000s that fundamentally changed the way we taught ACLS and BLS, because what you can see here is it does take us a fair bit of time to generate pressures, to start, when we start compressions, to generate good pressures that perfuse the heart. And you can see that over this period of time, which is about 15, we just get to probably good perfusing pressures, and then we stop. You see that pressure drop right away, and it takes us another 15 to go up. So this was one of the studies that led to us going from doing compressions on a more frequent basis, 5-to-1, to 15-and-2 to 30-and-2 in adults, as a way to ensure that we're generating the pressures that we need. So why is that important? When we're talking about doing CPR in the back of an ambulance, in the back of moving down a hallway, if you lose your balance providing that CPR, you're going to result in probably about we estimated a 2-second hands-off time. And that would be kind of 4 seconds where you're not perfusing the heart. And so even if you restart your quality CPR and you resume in 2 seconds, you haven't been totally thrown off your feet, that you can, it will take you probably another 2 seconds to get back to a coronary perfusion pressure that resulting from that aortic pressure that's higher. So from 50 transports in Richmond, Virginia, where I worked at the time, we actually had, at that point, we were one of the first ambulance companies that had the monitoring software within it that measured acceleration forces. So if you braked too hard, you would get points on your record, and then if you got too many points, you'd have to go see the safety officer to discuss how bad your driving was. But it was also helpful to kind of show how many, to measure the acceleration vectors that people would experience on the back of an ambulance. And so we took 50 patients who were transported to the hospital with cardiac arrest, took their acceleration vectors and measured how often or what percentage of the driving time were they subjected to unbalancing forces, so that even the best person standing upright trying to do CPR, may or not be able to do that. And you can kind of see at the different speeds that people were going. We compared it to cardiac arrest versus routine transports, and showed that even if you turn off your lights and sirens and you're going fast, you were probably subjected to a fair number of pressures, which results in a fair bit of port time. And so high quality CPR is something that, if you leave this talk with anything, I'm going to reemphasize this, because we can talk about all the advanced technology, we can talk about all the ICU techniques that we do, but high quality CPR is the thing that underpins all of this. And we want to be able to kind of repeat off that we want to be able to do compressions with the backboard. If you're not standing upright or you're not dropping your stretcher down, in the hospital we talk about using a step stool, talking about rotating compressors or using a mechanical compression device, and then ensuring that we're providing the rate, ratio, depth, recoil, and to minimize interruptions. And then if you're getting at the advanced level, end-tidal CO2 arterial line monitoring. But to me, it's not only about providing high quality CPR, it's also about the safety of providers as well. And we know that actually one of the most dangerous things that we can do is drive an ambulance, respond code one, lights and sirens, whatever you call it in the region, to a scene, and then taking that patient to the hospital. And if you're unrestrained in the back of your ambulance, that results in a high number of injuries, high number of crashes, high number of injuries, and even deaths, not only of the occupant of the other vehicle, but of the ambulance driver, EMT, the ambulance passengers. And many times it's oftentimes without the use of restraints that you can kind of see that both non-incapacitating injuries, incapacitating injuries, and fatal injuries were associated with the lack of safety restraints. And 84% of our EMS providers in the patient compartment were not restrained. So while I am talking about E-CPR, I'm talking about transporting these patients to the hospital. And I know that we have devices that are out there, and I actually don't know the availability of that within Baltimore County. It's important to come back and talk to that. If we can't deliver high quality CPR and we can't do it safely, is it something that we should be doing? So I'm going to pause right there and see if there's kind of any questions, because I've given it both a little crash course in ECMO, crash course in E-CPR, and then took a little negative spin there by talking about safety during transport. All right. So going on is, who should we put on ECMO? And this is something that there's some consensus in, but there's not necessarily a large amount of consensus. So in the pediatric population, where I think we tend to be a little bit more bleeding heart, because it's just because they're a kid, we look at they did a survey about 4 years ago and then reported in 2022, where they took kind of 4 different patients scenarios and asked, a number of providers whether or not they would do E-CPR for them. And this included a patient who just underwent heart surgery, who underwent refractory cardiac arrest. There's no bleeding. There was a patient who was admitted for cardiac failure, who resulted in cardiac arrest. Those both had cardiac diagnoses. Patients with non-cardiac diagnoses, a patient who had septic shock, and then another patient who was complex with a history of prematurity and chronic respiratory failure. And this was an international survey that kind of included duration of time, clinical determinants as well. And they had over 250 respondents with 10 years of experience, many of whom were pediatric critical care. And you can kind of see that, none of these scenarios were no-goes for these patients, for these providers, but they would absolutely consider the time as one of the first factors that are considered between the different scenarios. That in scenario 1, they would always do CPR no matter how long, and that was a patient who just underwent heart surgery, likely was still in the ICU, probably receiving high quality CPR. But you can see that, depending on the scenario, they may or may not offer E-CPR at different rates. So that last one, that complex patient, there's a number that would, but somewhere around the order of 15%, but the vast majority of providers would not. Other factors that would be involved is they considered where the patient was. So this is not talking about out-of-hospital cardiac arrest. They'd consider, the lactic acid that you could measure, whether it was a lactate level that they wouldn't do it, whether there's epinephrine doses that they wouldn't, whether there's an ECMO team that was already there. And then, they did consider in-hospital cardiac arrest versus out-of-hospital, and showed that most people would not really consider out-of-hospital cardiac arrest, but it was really important that, it needed to be witnessed. And, if it was unwitnessed and the bystander provides CPR, that decreased the outcomes as well. In the chat, there's how many EMS systems are doing E-CPR in the field, and it's just, as far as I know, it's just one. That one in Minnesota is the one that kind of has really kind of pushed the boundaries. So I know there's a lot of agencies considering it now. So when we look at this again, and this is just in hospital CPR, so building on the study, it's one of those that I think shows that E-CPR is beneficial. It increases survival compared to conventional CPR, and especially when CPR is greater than 18 minutes. And in children, this is something that we kind of know is true. And most pediatric cardiac ICUs, most pediatric ICUs do provide this level of care for our patients. And it's not just, and when we look at it, it's also CPR duration, that E-CPR with those longer events. So putting patients on too quickly may or may not be beneficial, because it's a survival to discharge if they only have an arrest of 10 to 18 minutes, but it's those longer arrests that seem to benefit the most, increasing their odds of it. So what are the steps in E-CPR? So I'm going to harp on this again. So this is a diagram kind of, showing the complexity of it. So it involves, providing that high quality CPR, which is having that backboard, that step stool, utilizing the CPR coach. And when you look here at the imaging on the right, you can kind of see all the different people that might need to be in the room. Initially just providing good high quality CPR. And this is not yet at the point adding in the cannulator surgeons and others. This is just doing a good arrest. Now, we know in the field, at times you may have this number of people, at times you may have far less, you may not have this level of training. You may not have the number of personnel there, you may have a lot of people there, but you may not have the number of people with training. So we know it's going to be very different, and this is where mechanical CPR play a role. So the diagram that we looked at before, kind of showing the importance of this, it just harps on that, if you don't do good CPR, we won't have good neurologic outcomes, even if we get the patient on ECMO in a good period of time. So I'm going to harp on that again, especially when we get to the point when we can talk about what we're doing locally. So in the hospital, we do talk about activating E-CPR early. So for us, that's, talking about E-CPR. If the arrest has been going on for 5 minutes, or we're giving that second dose of epi, we kind of have a trigger point in the kind of verbiage that we have, where the charge nurse or others can say, hey, we're giving our second dose of epi, should we activate E-CPR? And then we use internal messaging using Tiger Connect, so that we can say E-CPR, because that should change how we respond to the resuscitation, because it brings in a lot of other people. And then we have to prepare the room. So we take that already complex diagram of the resuscitation with the different people there, and we add in even more people. And as you can kind of see here, you have the room at N, and then you have the room and ECMO, where in pediatrics, we have to bring in an OR table. We have to bring in surgeons. We have to maintain compressors. We have to bring in attendings. And we also potentially have to even bring in an echo machine to be able to monitor for it. And so it fundamentally changes how how many people are involved, how this gets activated. And when you come to Maryland, you come to our adult ED, it brings down people from our critical care resuscitation unit. It brings down our people from our cardiac surgeons. It's a pretty resource intensive just to do this in the hospital. So we're not even talking about loading things up and putting them in the back of an ambulance or in the back of a truck to bring them to. Another diagram from another organization that kind of looks at how to do E-CPR cannulation, which for us, in pediatrics, since I'm talking about going to the neck, does involve moving the patient around. But it shows you the purple regard is the number is people, and then the tables and other carts that are in the room. So it shows you the amount of equipment that's there. So a key component in the E-CPR is including the sterile compressors or using the Lucas device, which allows us to provide good high quality compressions while the surgeons are doing their thing. But it doesn't also, the steps of E-CPR does not just include the steps of resuscitation. It includes many other team members as well, including our pharmacy, our blood bank, and our perfusionist, to show you that it's not just a single person who can respond and put someone on. It's very much a team response. So why are we doing this? Why should we do this? Because I think that the stories are there. In pediatrics, this is something that we're a little bit, I think, a little bit more aggressive on. We have, kids who have ridiculous stories. So this was a child in Pennsylvania who had an unwitnessed arrest, who was brought in by EMS, taken through 2 different hospitals. And while he never actually required ECMO, you can see that he's overall doing well. He did have a unique factor of a cold water drowning. And for us, actually at Maryland, we have a hypothermia protocol and have actually had pretty good outcomes with patients with pretty severe hypothermia coming through shock trauma, and placing them on ECMO, rewarming them, and having them walk out of the hospital. And it's not just, it's not just East Coasters here. It's spread throughout. In Rady, you can see actually with Emma here, not a patient I was involved in, but she also has the scar on her neck, which tells us how she went on ECMO. She arrested in the field, was taken to another got ROSC, was taken to another hospital, arrested again, got ROSC, arrested again, had 40 minutes of transport, was brought to Rady Children's, placed on ECMO, and was discharged home. So E-CPR, kind of highlighting again, is a rapid deployment of veno-arterial ECMO to provide circulatory support, and time is a big factor in what we're doing. I only allude to that there's other aspects to post-cardiac arrest management that require that E-CPR does not treat, and that are really important and fundamental. Not a reason not to do this, but this is something that is a pretty resource intensive anytime we admit a post-cardiac arrest patient. So locally, what's involved? So these are our MIMS guidelines, where I think that the people who sit on the MIMS guidelines on the adult side are pushing it. They're suggesting that patients who are presenting with refractory ventricular fibrillation or pulse rate VT should consider ECMO and should consider E-CPR. So if you've defibrillated twice, and if your patient meets E-CPR criteria, to begin packaging for transport, all the way up at the first defibrillation and after the second defibrillation. And while we'll talk about what an E-CPR capable center is, because there's really only two currently in the state of Maryland, that you need to have an advanced airway, you need to have a mechanical CPR in place, and the criteria that they look at is the age. We limit it down to 60. That it needs to be witnessed with bystander CPR started, and it needs to, and that can include a patient who rests on you. Their initial rhythm needs to be shockable, and then I think the thing that makes E-CPR potentially out of reach currently for most of Baltimore County is that they say the transport time should be less than or equal to 15 minutes in E-CPR capable hospital. From what I understand, and you all might know a little bit better, the only two hospitals that are providing out of hospital ECMO or E-CPR is the University of Maryland and Johns Hopkins. And whether that's 15 minutes transport time or not is important. So putting it all together, for me, in the right conditions, there is a patient that may benefit from E-CPR with an out-of-hospital cardiac arrest. If the bystander CPR is high quality, or we can coach high quality CPR via the phone and outreach, and if we can do high quality CPR during transport, and if we can do it safely. And I harp on this that captures the importance of the CPR we provide. And that's, I think, why the guidelines insist on an advanced airway where we can do continuous compressions and a mechanical device as well. So the best way to improve E-CPR outcomes is really to consider it early. We use a prompt of a second dose of epi. MIMS uses a prompt of the second defibrillation. It's something that could be considered in the right patient. I think if you truly had that refractory VF patient that you're bringing downtown for ECMO, that would be the patient that I would do it on, and kind of take that extra effort. The challenge is that you kind of have to make that decision early and start the ball rolling early, because if you arrive too late, or even if they seem to be the right patient, if we're not able to get them on time, their outcomes drop kind of almost every 5-minute increment that we don't put them on ECMO. So overall, ECMO is complex. ECMO does involve a lot of technology. It does involve a lot of resources. E-CPR requires a lot of that provided very quickly. And while ECMO is something that is near and dear to me, I do struggle with the limits of when we should do it and when we shouldn't. And so to me, it's something that's worth kind of talking about early. MIMS is pushing us by creating guidelines. And I don't know if we've really hammered out the details in this region. Now I work on the pediatric side, so these type of patients are extraordinarily rare in pediatrics. They're rare in adults, but I think it's something to think about, talk about, and with the right patient, push the boundaries because it may benefit that patient as well. So that's where I'm going to wrap up and see what questions people have.
I find it interesting, and I think it's the future, but the distant future. We see it in the hospitals now for in-hospital cardiac arrest, especially interoperative. We've done this at Sinai for intraoperative cardiac arrest. And then what's interesting is we usually transfer them to the University of Maryland if we're successful. It's very expensive, it's very resource intensive, and it's still very new. But it has been demonstrated to work. So who knows? 10 years from now, it could be much more.
So there's a question in the chat: how long do you think it would take for this to be widely used by EMS? I think it just really depends on the agency. So I've worked in a number of agencies when I was in EMS, with kind of varied pieces. I think the first and foremost question is response time. If we can get to the patient in cardiac arrest in that 6 to 9 minute window, which we know is able to be done, in some areas. So, we do talk about Seattle, you do talk about Austin, you do talk about some of the more progressive areas that have pretty rapid EMS deployment, then, that's, I think, the first step. After that, the other piece is bystander CPR. I know Baltimore City is actually really bad at bystander CPR. Regions of the country that have high levels of bystander CPR do much better, and public access AEDs. So for me, we can't even, I think the thing that was very stark to me as a paramedic and then kind of as an early physician, I moved from Richmond, Virginia. I'd been a paramedic at that point for about, at finishing medical school, I'd been a paramedic about 10 years at that point. I'd been interpreting 12 lead EKGs, bringing patients to the cath lab directly from the ambulance, as early as 2006. And I moved to Chicago, and there was an article in Chicago in 2012 that had talked about how proud they were that they got 12 lead monitors for their ALS ambulances in 2012 using a grant because they were hosting the G20 summit. And it was one of those stark things to me, thinking about in Richmond, Virginia, we had about 100 medics. We ran about 15 to 20 medic units at a time. A city like Chicago runs 1,000 or not, maybe not 1,000, but they have over 1,000 medics. They have to train, credential, get up to it, and they'd have to buy 500 monitors. And in the times of budgets as we're experiencing right now, I think it's a heavy resource. 12 lead EKGs at that point, which I think are now a routine expected thing, and something that I'd been doing for 10 years up to 2012, would be behind. So I think this is something that a progressive agency could do and should do. And I think that, Maryland is pretty progressive in that nature. So I think having hospitals willing to put these patients on is the first step. So making sure we can get these patients to the hospital, I think, is where we should start. Another question is how many providers in a crew in the back of an E-CPR unit? I don't think that's been figured out. I think the agencies that have done that, do include 1 to 2 surgeons to place the patient on. Sometimes some of the places include an anesthesiologist, nurses, perfusionists. So you're talking about 5 to 6 people from the, from the ambulance side, because I would say within the hospital in general, on our adult side, we do this about, I think, 30 to 40 times a year in hospital. So if you think about the number of people you'd have to train to get everyone up to that same level, who would do it more than once every 5 years, it's going to take a lot to get there.
Question for you.
Yeah.
Very interesting talk. Are you doing any mixing and matching of modalities here? That is, are you doing cooling ex vivo while you're putting a person on ECMO? And has anybody done any studies comparing cooling on ECMO versus normothermic on ECMO?
Yeah. We don't do ex vivo cooling during resuscitation or arrest. We actually did do a trial on that when I was a paramedic back in Richmond that really kind of showed no benefit to cooling during the actual cardiac arrest period. We do study, we have studied kind of hypothermia versus normothermia. And ECMO actually is the easiest way to maintain hypothermia because we basically take the patient's entire blood out and we can change it based on a cooler for them. And we've, and I think Dr. Sagal can talk about this more, we've been successfully taking patients through bypass machines and cooling them down over time. We are studying separately, not purely related to ECMO, or studying again therapeutic hypothermia in both adults and kids, because I think the data is still relatively mixed on if it's beneficial or not. I will say I'm a believer in therapeutic hypothermia. I'm someone who will offer that to the right patients. The question is who are the right patients, and that's the studies that we're doing right now. And ECMO actually is the easiest way to cool a patient. Otherwise, we're using kind of surface cooling techniques with devices to do it. So for me, if you've made the decision to put the patient on ECMO, you're probably keeping them at normothermia right now. If you're going to take them to hypothermia, if the data really kind of pushes us there, or it's the patient that you think would benefit from it, it's easy to do. I don't think we'd ever really be able to study because the numbers overall of these patients are pretty low.
Very cool. Thank you.
I'll admit I'm a big fan of hypothermia after cardiac arrest. It's based off of personal experiences.
Just realized I talked really fast. I thought I was going to be talking for an hour. My apologies. I had a lot of slides.
It's an interesting topic. It's the future. It's like I said, it's happening more in Europe. In Europe, you have more physicians who ride ambulances than in the United States. And it's very interesting. But a lot of anesthesia providers ride ambulances in Europe because they're considered resuscitation physicians. So, remind everyone, if you would like CME, there's a link in the chat. Please utilize it and print yourself a copy.
All right, I talked really fast, so yeah, if you guys have any questions about this, especially kind of in adults, I can connect you with our adult ECMO program. And if you have any questions about kind of pediatric critical care patients that end up at Maryland, don't hesitate to reach out to me. I'm happy to kind of connect and provide any feedback or follow-up on patients.
Well, thank you everyone for attending. Thank you, Dr. Dante, for your talk. Definitely very interested. Definitely very future.
Yeah.
It'd
I
be-
think I'll say we were caught by surprise when MIMS kind of outrolled their guidelines, at Maryland being like, wait a second, hold on, we're not providing this. How do we do this?
right. And I think it took a lot of places by surprise. A lot of your level 1 and 2 hospitals, not university or MIMS, are like, what?
Yeah.
And I don't think this was on anyone's radar in that regard.
Yeah.
So, I mean, I think the
It looks
first,
like we got one more question, which is vector changes or DSED for E-CPR. So that's, providing kind of, correct me if I'm wrong, that's providing, changing the kind of pad locations or providing double pads to have a kind of additional kind of shock for refractory VF. So that's within the MIMS guidelines. The next page here does talk about that on the guidelines a little bit more. I definitely think it's a technique worth doing. It does have kind of increased success than standard shocks. In the hospital, or even kind of like if we put a patient on E-CPR, we will generally shock them out. But oftentimes what we do with E-CPR is we provide good oxygen to the heart, and that's more than enough to overcome. Or as we saw in the picture of the ambulances, that we can get them into the cath lab and reperfuse the heart. Thereby, we can actually leave the patient in ventricular fibrillation, put them on ECMO, provide them circulation, oxygen support through that, get them to the cath lab, open up their lesion, and usually get a perfusing rhythm back.
yeah, I think the secret's to the cath lab in that regard, because once you can get the coronary open, that's the best start for the best outcome.
And ECMO lets you it buys you that time.
Yes, ECMO is a bridge.
So it would be both at Maryland's adult ED or shock trauma can provide kind of E-CPR for cardiac ECMO, kind of post cardiac arrest related to the 45-year-old in the gym who has a ventricular fibrillation arrest. It'd be coming to the adult ED. For the kind of undifferentiated patient, sometimes it would be going to shock trauma. But since we're talking about right now, the guidelines are very much refractory VF VT, you'd be going to the adult ED at Maryland.
All right.
All
I
right,
want to
thank
thank
you.
everyone for attending. I'd love to thank our speaker.
Yeah, and I'll say, Dr. Sagal, at the end of the day, for me, can we do it safely? Like, I don't know. I've spent enough time in the back of an ambulance that I don't know if I'm doing this 100 times for one save, but if you do this 1,000 times and one of our providers die, I think that's something that has to be part of the conversation as well.
Doc, I didn't see the link yet to click on.
I can throw it on I can throw it on a slide. It's a bit.ly link. It's in the chat. Are you able to see it?
Members group. I see all the people. See all the people that are there right now. I see all the boxes.
The links on there's.
I just sent it again.
We just sent the link into the chat.
Okay. So
I got a message as we're kind of wrapping up, why is this not on the pediatric protocol? It's not on the pediatric protocol because there's 3 centers within Maryland that can provide ECMO or E-CPR, or 3 centers that we transport to, and that's DC Children's, Hopkins, and Maryland. I think the DC Children's would not do it because they view the success rate being very low. Hopkins was willing to do it, and at Maryland we struggle because we only have really one surgeon who's doing it right now. So it would be very hard for us to offer it for less than 13 on a consistent basis. So it was hard to make it a statewide protocol or even guideline when you only really had one hospital that was capable of doing it. I will say, trained at Hopkins, they will push the limits there. So if you do have the right patient and you call, they will absolutely push the limits there, and they would have the best. I think they would have probably right now with their staffing, they'd have the best setup to take care of the patient, even though I don't want you to say not to bring the patient to Maryland, but they would probably be the best if you have the right pediatric patient. Happy to. There's a question, is this something the Go team could do? I can ask that question to the Go team. I think the challenge is the equipment, and it's actually a different set of surgeons. Theoretically, the surgeons could learn it,
the equipment for that.
but it would be adding a fair bit to them, and I think the cost to it. So I know we've talked about that, but I have not been part of those conversations.
I think the equipment required for ECMO requires an ability to a larger amount of room for transporter space. I know the U.S. Park Police helicopters were asked if they could transport an ECMO patient, and there's the helicopters used for them. It would be very tight. So, because you have to have the perfusionist in addition to the equipment. So that's a helicopter's not the best unit for this. It would require a ground-based unit. And a regular sized ambulance would also be a little on the small side. It would have to be dedicated for such. I saw the picture of the unit from Minnesota. And it almost looks like a truck.
Yeah. I think this bottom right is their mock-up. So this is the actual truck, and then this is their fake mock-up that they made to see if they could fit everything in there. I think our challenge here in Maryland is we have a high dense hospitals that it'd be more interesting, I think, to figure out a way to do this, more consistently at the hospital spread it throughout the state, even if you place them on and then, and then funnel them to our ECMO centers. But then the challenge there would be like having cath labs open and available throughout the state. We struggle with some of the more rural places having the numbers as well.
Would be because they also looked at this with trauma even for patients, and it's labor intensive. Hospitals can do it, but can they do it 24/7? And most hospitals don't have a 24/7 cath lab. They have people on call, but it's not 24/7. So could a trauma team put someone on ECMO? Yeah, I think a trauma surgeon could easily do it. But then you need the perfusionist to run the ECMO, which means it has to be a heart center. And then you need to transfer them to the patient, to the centers after that effect, which is a specialty ambulance. But that part does exist.
I think my struggle here is you have to have, I think that just you need to either have the full system in place, because just doing it ad hoc, like as a last ditch effort, means that you've probably burned through a lot of your time, that your outcome is likely going to be poor. If you're doing it for the first time, just because, you should give it a try, because I mean, it's a delicate dance for us. As I said, our goal in hospital is less than 40 minutes. And we don't even achieve that 50% of the time. So it's kind of a bigger discussion for, if and when to do it.
I know at Sinai we do it less than 10 times a year in the ORs. All right. Well, if nobody has any other questions, we will bring this to a conclusion.
Thank you very much to all.